evening. Welcome and thank you for attending tonight's Ahead of Cancer lecture series, sponsored by the Allegheny Health Network Cancer Institute. My name is Michelle Stanicki, and I'm one of the project coordinators at the Cancer Institute. Before we begin, there are a few housekeeping items that we need to review. Number one, during the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Number two, participants are not able to speak during the conference, but again, we encourage feedback via the chat option. Our topic tonight is Unleashing Your Body's Cancer Fighters, Targeting Cancer with Personalized Immunotherapies. Tonight, we are excited to welcome Dr. David Bartlett and Dr. Thomas Curley. We are incredibly fortunate to have both Dr. Bartlett and Dr. Curley with us tonight. Before they share their insights on this topic, I would want to give a glimpse into their impressive backgrounds. Dr. David Bartlett is the chair of the AHN Cancer Institute and president of the Allegheny Health Network's Research Institute. An internationally recognized cancer surgeon, he is a pioneer in abdominal cancer treatment and a dedicated, prolific researcher. He is also the past president of the Society the Center for Cancer Research at the National Cancer Institute, where he developed innovative surgical techniques to treat patients with abdominal and liver cancers and performed cutting-edge laboratory research in viral-based immune therapies. In addition, Dr. Bartlett has received his medical degree from the University of Texas Medical School at Houston and completed his surgical residency at the Hospital of the University of Pennsylvania in Philadelphia, Pennsylvania. He continued his training with a fellowship in surgical oncology at Memorial Sloan Kettering Cancer Center in New York City. He had completed his research fellowship at MD Anderson Hospital in Houston, Texas, and the Hospital of the University of Pennsylvania. Board certified by the American Board of Surgeons, Dr. Bartlett holds memberships in several professional surgical and oncology societies. He received numerous academic honors during his career and has been chosen as one of Pittsburgh's best doctors every year since 2006. He has published over 390 research papers and medical journals and has contributed chapters to more than 40 publications. In addition, he lectures widely at the national and international meetings and conferences. Also with us tonight is Dr. Thomas Curley. Dr. Curley is a hematologist and oncologist with the AHN Cancer Institute, specializing in diagnosing and treating both aggressive and indolent lymphomas, as well as chronic lymphocytic leukemia. His research interest in tumor-infiltrating lymphocytes and CNS lymphoma, with academic interest in bone marrow transplant and cellular therapy. Dr. Curley earned his medical degree from Wake Forest University School of Medicine in Winston-Salem, North Carolina. He completed his residency at The Ohio State University Wexner Medical Center in Columbus, Ohio, followed by a fellowship in hematology at the Cleveland Clinic, Taussig Cancer Institute in Cleveland, Ohio. Dr. Curley is board certified by the American Board of Internal Medicine and also is board certified by the American Board of Hematology and Oncology. Welcome, Dr. Bartlett and Dr. Curley. I'm going to give it over to Dr. Bartlett. He will be leading us off. Thank you very much.
Thank you. Thank you for that nice introduction. And I'm excited to talk to everybody tonight about unleashing your body's cancer fighters, advances in immunotherapy. I know you all are very familiar with what this is, and it's one of the most exciting kind of new aspects of cancer care. And I've been involved with this since my work at the National Cancer Institute, which I am embarrassed to say was about 30 years ago. And we've seen this field just develop by leaps and bounds over the last 30 years, and it's really remarkable where we're at now and where we're going to be in 10 years with immune therapy. And this is just what we're talking about. The purple there is a cancer cell, and the green are immune cells. That's not their actual colors, but for the purpose of the artist, lymphocytes that are attacking this cancer. So they are bound to the cancer cell with specific receptors that recognize abnormal proteins on the cancer cells, and then they release toxic agents that then lyse the cancer cells and kill the cancer cells. And this is on the lower right here, a video of these T cells killing a cancer cells that one of my colleagues made. And the green are the lymphocytes, and you can see very blandly here a cancer cell. And you can see over time here hopefully this will work. We'll see if it works. Yeah. You can see the green cells surround, bind, and then just completely destroy that cell. And so that's what we're talking about. We're talking about using your own immune systems to attack the cancer. And the big issue is, why doesn't it clear all the cancer before it ever starts? And why, once the cancer has developed, don't all cancers respond to immune therapies? And that's what we'll talk about a little bit tonight, is what's specific about certain cancers that leads to these immune responses, and why doesn't everybody respond? And just, again, we have traditional cancer therapies like radiation and chemotherapy, and they are, designed to selectively kill cancer cells, but they also kill normal cells. And so there's a therapeutic ratio of how effectively they kill cancer cells versus healthy cells. And we play around with that ratio to try to optimize it. But the bottom line is, at the end of the day, we are killing normal cells with our chemotherapy and radiation therapy. And that's why we see a lot of the side effects. And, in a sense, these therapies are knocking down the body. Now, it makes sense to do so if we're also killing the cancer, obviously, as long as we're killing the cancer and the host can manage through the side effects. But cancer immunotherapies are completely different. We're taking the existing immune system that the patient has, which is very, very selective and targeted to these abnormal proteins specific to cancer cells. And, then that therapy can very selectively kill the cancer cells without killing the normal cells surrounding it. I will talk about some side effects associated with immunotherapy. So even though conceptually it's much more selective and a much healthier way to treat patients, because it's not knocking down your body, it's actually building up your body at the time that it's using treatments. But there are side effects that we need to keep in mind whenever we're using these treatments. And this is the history of immunotherapy, and it is quite amazing what's just happened over the last 10 to 20 years now. But it started back in the 1890s, where Dr. Curley had a patient with a head and neck cancer that developed a bad infection, and the tumor went away spontaneously. And Dr. Curley made the observation that perhaps it was the bacterial infection itself that led to a response in the cancer. And so he was able to isolate the toxins that these bacteria developed, or that these bacteria produced, and then began giving those toxins to patients. And he did see some responses, not across the board, but he saw some very dramatic responses. And it was called Curley's toxins. And so that was kind of the background of immunotherapy. And it wasn't then until 80 years later that we began to understand the immune system. Dr. Steinman up in New York as well discovered dendritic cells in 1973. After that, we started using vaccines in the form of BCG, a foreign protein that, again, similar to Curley's toxins, could be injected into cancers, and the inflammatory and immune response could then eliminate the cancer, still being used today for bladder cancers. And then monoclonal antibodies that target cancer, transfer of T cells, which is something Dr. Curley is going to speak about. And then some cytokines, interferon gamma, and then these checkpoint inhibitors. And we'll talk a little bit about checkpoint inhibitors. But there's a lot of enthusiasm around immunotherapy in the 70s and 80s. And then when a lot of the new therapies just weren't transforming cancer care, there was some skepticism. But there's been certainly a renaissance here since the mid-90s, where so many new immunotherapy agents have been identified and approved. But Dr. Allison received the Nobel Prize for his discovery of checkpoint inhibitors. But it really took another 10 years for those checkpoint inhibitors to come into practice. Actually, 20 years between the discovery of those checkpoint inhibitors and the approval of a checkpoint inhibitor for cancer. And in the meantime, other monoclonal antibodies, interleukin-2 as a cytokine was approved for melanoma and renal cell cancers. And then cellular therapy came in to play in 2010. So that's kind of the timeline of where we are. And just there are different forms of immunotherapy. So there's cellular therapy, which is taking immune cells and delivering them to patients to combat the cancer. And again, Dr. Curley will talk about that. Immunomodulators like these checkpoint inhibitors, and you hear about these on TVs like Keytruda and others. These are immunomodulators. Then we have oncolytic viruses, live replicating viruses that infect and kill cancer and then induce an inflammatory and immune response. Monoclonal antibodies that attack these antibodies, molecules that bind to the cancer and then lead to an immune response. And then cancer vaccines, trying to prevent cancer before it happens, or in patients when they've had like a surgical resection and they have what we consider minimal residual disease, trying to use a cancer vaccine to treat that. And BCG is kind of an example of a cancer vaccine. But here are the list of drugs in these different classes. So for checkpoints, you've got the CTLA-4 inhibitors, like ipilimumab. We have PD-1 inhibitors, and these are the ones that have been most exciting, like Opdivo and Keytruda that you hear about on commercials. And then some cytokines that boost the overall immune system. These include the interferons, interleukins, growth factors. It's approved for therapy in melanoma, and these names are all extraordinarily complicated, so I'm not going to try it, but we call it TVEC, and it's a live herpes virus that you inject into a tumor, and it replicates or it divides, kills the cells, divides some more, divides, kills the cells, and just induces this immune response that can improve overall survival. BCG is, as I said, known as a vaccine. And then we have non-specific immune stimulators, these toll-like receptor agonists. And imiquimod is the one that you put on you smear on your skin to get rid of skin cancers, which has been very effective. So that's the classes of different immune therapies for cancer and examples of different drugs that are currently in practice. And this is the key, and this is a graph showing the chances of responding to an immune therapy on the left here on the y-axis. And on the x-axis is the tumor immunogenicity score. And what that means is not all tumors are the same. There are some that we consider immunogenic. In other words, the immune system will eliminate if we figure out the right tricks. And then there are those that we consider very cold tumors, non-inflamed tumors, non-immunogenic. And these are the ones that tend not to respond to immunotherapy agents. And, so as you can see, a tumor like melanoma is very immunogenic. And that's why the majority of immune therapies that exist today all work against melanoma. Now, not every patient, not every time, but melanoma has a much higher rate of response to immune therapies than, for instance, pancreas cancer. Pancreas cancer is way down here. It's not immunogenic. And how do we determine immunogenicity? There's different ways. In this specific example, immunogenicity is determined by the number of mutations your cancer has. And so the thought being that if your cancer has 1,000 mutations, it's usually much more than that. Let's say, for example, if your cancer has 1,000 mutations, then those are 1,000 different proteins that the immune system can react to. And the chances are one of those, the immune system is going to react positively and it's going to be considered immunogenic. Versus a cancer where there's only a handful of mutations, let's say 5 mutations. In that case, it's much less likely that one of those mutations to be, quote, immunogenic. And so it's worth keeping in mind because everybody, if you have pancreas cancer, you're thinking, wow, why aren't I getting immune therapy like the melanoma patients? It seems to work so magically. And the reason is because it just doesn't work in those types of cancers for the most part right now. The trick that we're all trying to figure out is how do we make these low immunogenic tumors, breast cancer, these prostate cancer, brain tumors, pancreas cancer, how do we make those more like melanoma and more immunogenic? And so that's the trick that everybody's working on, because eventually we're going to get to where we find immunotherapy solutions to all of these cancers, I firmly believe. And this is the checkpoint inhibitors, just to start there, where normally tumors that don't, they resist immune clearance. So they don't want the T cells or the immune cells to clear them. And so the tumors produce proteins that block the immune cell. And so you can see in this example, you've got this blocking protein on the surface of the tumor, and it completely shuts off the immune cell. And what these checkpoint inhibitors do is they create a barrier so that that protein on the surface of the tumor cell can no longer shut down this immune cell. So you can imagine what happens in these tumors is that all these immune cells are sitting there wanting to kill the tumor, but they can't because the tumor has blocked it. So we put that checkpoint inhibitor in, that drug in, and now this T cell is activated and that T cell can kill the cancer. And here are all the different types of cancers where an immune therapy, a checkpoint inhibitor specifically, PD-1, PD-L1, which is just one of those proteins, but there's multiple proteins, but this is the one that's out there. You can see all of the tumors that the FDA has approved therapeutics using this drug. So from melanoma to liver cancers, to lymphomas, to triple negative breast cancer, all of these now have immune therapy, this checkpoint inhibitor as a therapeutic. You can see active multiple other cancers that we just haven't gotten to the point of being FDA approved, but that we think will get there in the future. And then some that just don't seem to have any activity, pancreas cancer being one of those. And so, these are, and then here are the drug names that we talked about with these agents. But this is just an explosion of, new cancer therapy options with these checkpoint inhibitors. And I'll just talk briefly about TIL therapy. Again, Dr. Curley will talk about this, I think, in more detail. We grow the T cells, these immune cells, out of the tumor, expand them, and then give them back to patients. And then there is an approved drug now for this that Dr. Curley will talk about, CAR T therapy, which I'm sure you've heard about, another cell therapy where the cells are taken out of the patient and then, up here, taken out of the patients and then genetically engineered to have a new receptor that can recognize cancer cells, expanded, and then given back to the patients for cancer therapy. And just as an example, and you might hear this a second time, but you can hear it 10 times and probably still um, it'll seem new. But these are all the drugs, which again, I won't try to pronounce, that are now commercially available for CAR T therapy for different kinds of cancers. All of these right now being hematologic malignancies, so lymphomas and leukemias and myelomas, not solid tumors. And the solid tumors are the ones where we struggle getting these cell therapies to respond to, especially these CAR T therapies, but a lot of people working on that. And then just the newest cell therapy approval is for a TCR transgenic T cell specific for synovial sarcoma, a rare form of sarcoma. And uh, so in this case, the cells are genetically engineered to express a T cell receptor, which is specific not only to the type of cancer, but also to the patient who has certain HLA types similar to their transplant antigen. So it's a very specific, very targeted therapy that has recently been approved. Now, immunotherapy, like I said before, was originally thought to be the most perfect treatment that would only target the cancer and not target anything else. But here's what we found when these went into practice is that there are a lot of side effects associated with these immune therapies. And the reason is that your immune system is in constant equilibrium with your own body, which means that your own body produces certain cells of your body kind of combat that immune system so you don't destroy your own tissues. So when we release those checkpoints or those brakes on the immune system, we can start to see the immune system attack our normal organs. So that's one problem that we see is that there are some natural kind of autoimmunity to normal tissues that and that autoimmunity can be released by these checkpoint inhibitor drugs, and that can lead to encephalitis, some brain problems, some pneumonitis being relatively common, where the lungs get inflamed, and that can cause problems. Myocarditis, where the heart gets a little inflamed, hepatitis, where the liver gets inflamed. The nice thing is when these problems happen, if you stop the drug, it goes away. So you have to monitor very carefully, and when you see the toxicities develop, you have to stop the drugs or decrease the dose of the drugs. Obviously, if you do that and the tumor is in the process of responding to treatment, then you can see the tumors start to regrow. And sometimes you have to go back and forth where we have to reintroduce these immune therapies and wait for toxicities, then hold them when the toxicities develop and kind of go back and forth. But for the most part, these are very well tolerated drugs, again, that can magically get tumors that used to be completely resistant to chemotherapy to disappear. And I've had the pleasure of talking to patients right as these immune checkpoint inhibitors were coming out. I remember specifically a breast cancer patient that I saw socially that said, she was out of options with the expectation of dying of her disease and being referred to hospice. And one of these checkpoint inhibitors came on the market. She tried it and it worked, and it represented a life-saving treatment for her. So these are very dramatic life-saving treatments, but only for the certain cancers that we've talked about. And then finally, I'll just end up with a little discussion of the oncolytic virus immunotherapy. This is something that I've been working on in the laboratory for 30 years now, is developing viruses that can attack cancer cells and grow and replicate, divide, and get released by those cancer cells. And then those viruses spread to other cancer cells. So you only have to infect one cancer cell, and the virus can spread through the tumor and kill all the cells. But the nice thing is that these viruses are engineered so that they don't kill or they don't divide and replicate in normal cells. And so this is just a schematic where this virus is a lot of viruses come out of that. And each one of those viruses goes on to kill a surrounding cancer cell, but not the normal cells. And so this is a very selective cancer treatment using a live virus. So you don't have to infect every cell. You just have to infect, in theory, one cell, and you can see the impact of the live virus. And this is a study, and it's very complex, that we're just getting started with at Allegheny Health Network. And what we're doing is injecting tumors directly with this virus. And what we use is a pox virus called vaccinia virus. And we've engineered it so that it doesn't infect normal cells, but does infect and replicate in cancer cells. We did that by mutating genes in the virus that are essential for it to survive in normal cells. But cancer cells make up for those lost proteins, harvest that harvest that tumor, and then collect the immune cells that we recover from that tumor. So the thought being that by injecting it with the virus, and we have proven this in our animal models, is that by injecting the virus into the tumor, we now develop immune cells specific for that tumor, and then we can harvest that tumor, grow those immune cells that are specific, expand them, activate them, and then reinfuse them into the patient. So we're just getting started with this first part of the study where we inject the tumor with the virus, and then we excise the tumor and we kind of see what we can get. But the future is that we will then expand those cells and give them back to the patient. So it's a very complex treatment, but kind of exciting to have this technology available to us here at AHN, and for us to be able to offer that to patients. And obviously, every time we start a new clinical trial with a new agent, we are hopeful that that will be the magic that really turns these non-immunogenic solid tumors into very immunogenic tumors that can then have a nice response to the immunotherapy. So in summary, immunotherapy will continue to improve, and the indications for immunotherapy will continue to expand as we develop new treatments. We have 2 checkpoint inhibitors that are currently in practice, and we have about a dozen more that are in clinical trials that we expect will be in clinical practice in the future. So this field is exploding. This turning cold respond to immunotherapy, and so that's part of research that we will sort out in the future. A lot of the approvals for immune therapy is in combination with chemo and radiation. So it may not be one or the other, but it may be a combination that's most impactful. And so there are a lot of drug regimens that include chemotherapy and immune therapy, and that have shown very successful and have been FDA approved. And then, I project that all patients will have immunotherapy options 10 years from now. I know that's kind of a crazy projection, but I do believe that with so much research and this explosion in immune therapy that we'll get there. So I'll hand this over now to Dr. Curley. And Dr. Curley, in addition to the great introduction that's already been given, I'll just say is taking over for all of our cell therapy trials in solid tumors, and so has a lot of very interesting and exciting immune therapy trials that he's working on.
Thank you, Dr. Bartlett. So my aspect of this presentation, titled Unleashing Your Body's Cancer Fighters, Targeting Cancer with Personalized Immunotherapies. And just a overview of what this presentation is going to be. So the first thing is cellular immunotherapy for solid tumors, kind of breaking things down by 7 things to know, as well as tumor infiltrating lymphocytes, or MTAGV, which is the FDA approved TIL product for melanoma. And then lastly, a little bit about cellular therapy at Allegheny Health Network. So the first question, what is cellular therapy? And very similar to what Dr. Bartlett had already discussed, lymphocytes, or white blood cells, are an important part of the immune system that help the body fight off infections or eliminate disease cells. Lymphocytes are made up of T cells and B cells, and they're constantly patrolling the body to identify cells that shouldn't be present, including cancer. As cancers grow, lymphocytes recognize these cells as abnormal and penetrate the tumor. And once in the tumor, they begin working to kill cancer cells. So sometimes they're prevented from doing this by breaks in the immune system or signals from the response that weaken the immune response. As Dr. Bartlett discussed, immune checkpoint inhibitors were developed to block some of those breaks and unleash the immune cells to attack cancer. We can use the lymphocytes themselves with some improvement as a form of therapy. So what are the different types of cellular therapy? So similar to last presentation, on the right side is CAR T therapy and T cell rearranged therapy, which basically involves isolating a patient's peripheral T cells and introducing a target for these cells to attack the cancer. But what I'm going to be talking about is TIL cell therapy on the left, which is tumor infiltrating lymphocytes. It involves a tumor resection, a TIL isolation, as well as TIL expansion. And I'll go into a little bit more detail of that in upcoming slides. So how can these cells be used for cancer therapy? Because TILs come directly from the tumor, they already recognize many targets on the cancer cells. This makes them a very attractive therapy because we don't have to do anything to point them toward the tumor. A group of TILs taken from a patient's tumor may recognize many unique targets. And this is a key difference between this kind of therapy and CAR T therapy, where that can only recognize one target, but this can recognize multiple targets. This offers a real therapeutic advantage because it prevents the tumor from evading our efforts by hiding one target at a time. So to use TILs as a therapy, we must help them overcome the hurdles in tumor environment and effectively eliminate the cancer. And we can do this in 2 ways. First, we can expand the TILs, and second, we can make the immune environment more friendly to these cells. By expanding the TILs, we can give the patient a much larger army of immune cells that's already trained to recognize and attack that patient's specific tumor. So what's the treatment process for patients who undergo TIL therapy? So currently, TIL therapies for non-melanoma solid tumors are only available through clinical trials. For patients who enroll in a TIL clinical trial, the process begins with a tumor biopsy. This biopsy is then taken to a clinical laboratory to isolate the TILs. We perform the expansion and engineering in a process that typically takes about a month. And we're working to improve our speed in this area to get therapy to patients more rapidly. When the TILs are ready, we give the patient a short-term chemotherapy regimen to prepare the body for the cells. And this isn't so much as killing the tumor, but eliminating certain T cells and inflammatory products that may compete with the TILs for resources. Then the patient receives the TILs through infusion, just like a typical blood transfusion. Once infused, the TILs travel directly to the tumor to begin their work. Afterward, the patient receives some immune modulating therapies such as IL-2 or interleukin-2, and this helps stimulate the TIL activity so they can work to fight the cancer. TIL therapy is a one-time treatment. A patient will be in the hospital for at least 2 to 3 weeks so we can monitor for any side effects or reactions to the therapy. What are the expected side effects to TIL therapy? So far, we have not seen major side effects from the TILs themselves. Most side effects we see come from the chemotherapy regimen in low white blood cells, low hemoglobin, and low platelets, or the IL-2, which is an inflammatory product, which can be managed inpatient. We're working to engineer TILs that could produce their own immune stimulatory signal. This would eliminate the need for us to treat the patients with IL-2 and could potentially reduce side effects. So has TIL therapy been successful in treating cancer? So in a couple slides, I'm going to show you the data that led to Amtagvi being FDA approved. We've been evaluating TIL therapies in clinical studies for years, and there are encouraging results in early phase studies. Most of the studies thus far have treated patients with melanoma, but now other types of cancer are being explored. While there's early data, we're working very hard to understand how patients remain in response and maximize benefits for all patients. We're also working to improve the manufacturing process. So why are we excited about the future of TILs? We believe that TIL therapy offers a promising options for patients with solid tumors. By the very nature of TILs, we have years of data demonstrating them to be more successful for these cancer types. And very exciting that FDA approved the first TIL therapy for metastatic melanoma in February of 2024, which is called Amtagvi. We believe TIL therapy is poised for a significant impact in the field of cell therapy, and we're proud to be part of bringing those advances to our patients. So just a more detailed outline of TIL cell therapy stages. So it starts with tumor tissue procurement, which occurs as a surgical procedure. The TIL productions, the TILs are obtained from the tumor tissue and expanded in vitro. There's a preparative lymphodepletion regimen, which patients are lymphodepleted, meaning giving a low dose of chemotherapy while the TILs are expanded. Then there's the TIL infusion. So polyclonal TILs means express multiple targets to attack the cancer. IL-2 is then administered, and then patient is discharged from the hospital after usually around 2 to 3 weeks and followed up in clinic. So this is from the website of Amtagvi. It is the first FDA-approved treatment after progression on anti-PD-1, so that's a type of therapy used for melanoma, and BRAF MEK inhibitors, which is something else that can be given frontline for melanoma. So just a little background on metastatic melanoma. So there's estimated 13,000 advanced melanoma patients per year and 8,000 deaths from melanoma. More than half the patients progress within 12 months, even on current first-line therapy. And Amtagvi has, now that it's FDA approved, is now preferred as second-line or subsequent therapy, according to the National Comprehensive Cancer Network guidelines for treatment of cutaneous melanoma. It involved 153 patients. Overall response with these patients was 31%, which is significantly better than in the past for patients who have been refractory to one or more therapies. They did a durability look at 4 years of Amtagvi, and median duration of remission being not reached basically means at 4 years, more than half the people that responded were still in remission. So not only did we have a better response than classical therapies in the past, but these are very long remissions. So then finally, a word about cellular therapy at AHN. So TIL therapy, we currently have 5 clinical trials with cancer types including melanoma, lung, and endometrial cancer. TCR cell therapy, which uses a rearranged T cell receptor. So we have those in lung, head and neck, melanoma, cervical, and ovarian. And then CAR T cell therapy, which is still usually used for lymphoma, leukemia, and myeloma. We have 2 clinical trials involved in lymphoma. So summing things up, TILS therapy has been studied right now, and very excited about what this therapy is going to look like in 10 years. And that concludes my presentation.
Thank you, Dr. Curley. I think we have a few questions. Let's see here. First question. My best friend is getting a double mastectomy and reconstruction on Monday due to her diagnosis, invasive carcinoma, mixed ductal and lobular. Question, once breasts are removed, is there a chance of reoccurrence in the breast area? During that surgery, they will take lymph nodes to test for cancer cells. If I find out, what is the best treatment? I don't know if anybody wants to take that.
So I'm definitely not an expert in breast cancer, although, the truth is when you have a mastectomy, the chance of a local recurrence, in other words, occurrence around the incision where the breast used to be, is very unlikely. So very, very low chance of a local recurrence. And if they do find cancer in the lymph nodes, then they do recommend chemotherapy to treat any cells that might have escaped the lymph nodes into the rest of the body. So they do recommend chemotherapy in those situations. Still, even with lymph node disease, curable, but it does indicate extra treatment.
Okay, our next question. Where is GBM on the immunogenic scale?
Yeah, so it's low, unfortunately. However, there have been some responses to immune therapies, and so uh, so it is, but it is low on the immunogenicity score. So it really does not respond to immune therapy as well as other tumors. But there have been some responders. I think the response rate to checkpoint inhibitors, for instance, is in the 5 to 10% range. And a lot of studies ongoing with immunotherapy for brain cancers.
Okay, our next question. When is a cancer vaccine used?
So right now, and please, Dr. Curley, correct me if I'm wrong or weigh in where you're comfortable. But the cancer vaccines are currently not approved in general for any cancer therapy. So they're all in research right now. The only one that we talked about a little bit was BCG, which is referred to as a vaccine, and that's really only indicated for bladder cancer right now. So the vaccines would be used at cancer, but there's a risk for recurrence treating patients with a vaccine at that point. And there have been some trials in even pancreas cancer I just heard about recently showing some promise, but nothing that's been proven effective to date. So we're still only using them experimentally.
Okay. Our next question. There seems to be a lot being said about cancer prevention by following certain nutrition programs, avoiding certain foods which are said to feed cancers once they are present. Sugar intakes, for example, fasting to starve the cancer, letting the body heal itself in fasting periods, and other ways of eating that are touted as slowing or preventing growth. How do these philosophies hurt or help the discussed treatment modalities?
Yeah, so I think the first thing in talking about how we manage these philosophies when we're talking to patients is a lot of times, either because of cancer or because of side effects from chemotherapy, people can sometimes have weight loss or reduced appetite. So in those cases, I do think it's very important not to limit diet too much and just eat what tastes good to you. So you're not losing weight, so you're still getting the nutrition you need. In terms of data on avoiding certain foods that are said to feed cancer, unfortunately, right now, there isn't any study that can confirm if there is a certain type of food that either prevents cancer or hastens the speed that chemotherapy works on cancer. Because it's very important when we're talking to patients, any recommendations we made is proven in a trial looking at patients, because we want to make sure that what we're suggesting to our patients has been tried and is safe. If someone's talking to me about a certain diet they want to follow as they're on chemotherapy, I would definitely talk to them and say, if that's something you're comfortable eating, you can do that, just knowing there isn't any real data to support it. But a lot of times people do feel better if they are on a certain diet, as long as they're not losing weight for it. So I do think there's always room for discussion in these types of recommendations.
Okay, our next question. It looks like there are a lot of promising treatments for cancer. My mom was just diagnosed with pancreatic cancer and will start gemcitabine and chemo next week. Are there specific advancing technologies for treating PC?
So, there are kind of standard drugs that have, more recently been approved for pancreas cancer. The gemcitabine and the Abraxane is the most common regimen, along with the 5-FU, leucovorin, oxaliplatin, and irinotecan. So there's two regimens that are commonly utilized, and truthfully, both of those regimens have shown nice responses, and so we're seeing nice responses with those regimens, and sometimes if people don't respond to one, they will respond to another, and so following closely and switching regimens if one isn't working is is indicated. Uh, the and those are the approved regimens for pancreas cancer right now. There are clinical trials of new drugs, especially targeting certain mutations. One that we are very excited about is the KRAS mutation, which is commonly seen in pancreas cancer. And there are clinical trials showing that these KRAS inhibitors can be effective. Now, it's not something you would start out with in a patient, but in patients that have failed standard therapy. So if you've gone through the gemcitabine and Abraxane and move through the irinotecan and oxaliplatin, then you try the clinical trials, and the KRAS inhibitors are the most promising right now. And as I mentioned, a lot of immune therapy studies underway, but nothing that's shown to be beneficial at this stage. But again, hopeful for the future.
For head and neck cancer patients.
You're muted.
Did you hear the
So
question? Okay.
for a trial for head and neck cancer, right now the trials are ongoing, so a little too early to see the data yet. However, the rationale behind this clinical trial for T-scan for head and neck is that the T-scan had very effective in lab use. So looking at in vitro or in the lab, it's had very promising effects. So this trial we're working on right now is seeing what's the safe dose to look and looking at initial response rates and side effects. So a little too early to tell, but I definitely am optimistic.
And our last question, can someone speak to known synergies with PD-L1 immunotherapies? High fiber diet and healthy gut microbiome seem to show potential. Also knowing these drugs are often combined with anti-angiogenic drugs. Do you see any other biomarkers being targeted in parallel for synergy?
I think there are a lot of synergies with specifically checkpoint inhibitors, and presumably will be with other immunotherapies. And the microbiome is one of the most interesting, which is that you can change the microbiome or the gut bacteria and have an impact on the response to immunotherapies, specifically checkpoint inhibitors. The mechanism of that is still not very well known. And so while there have been some observations and even some clinical trials that have shown that fecal transplants can impact survival, or not survival, but response rates in checkpoint inhibitors. So in other words, actually transplanting the stool from a responder to a non-responder can induce or allow for a response. So anyway, some very exciting research around that, but it hasn't made it to clinical practice at this stage. And so because the mechanism isn't quite understood and there hasn't been, kind of a large randomized trial to show its efficacy and standardized approach, there hasn't been, it's not in clinical practice right now. But there are a lot of things, including just standard chemotherapy agents, that seem to synergize with the immunotherapy. There's thoughts, although it's still controversial, as to whether things like radiation therapy synergizes with these immune therapies by kind of priming the immune response that then can be activated with these checkpoint inhibitors. So, I think right now we don't have specific recommendations. Again, I'll let Dr. Curley weigh in, but we don't have specific recommendations for patients that are getting these treatments in terms of a diet or fiber or, ways to impact their gut microbiome. But we are seeing some interesting research in this field.
Yeah, and I definitely agree with Dr. Bartlett on that.
Okay, looks like that's our questions for this evening. So if that's it, we'll close this out for tonight. We would like to thank all who've attended tonight, as well as Dr. Bartlett and Dr. Curley for giving their time this evening. As a reminder, tonight's lecture was recorded and will be available on the YouTube, our AHN YouTube channel, in about a week or so. This also includes other videos of all of our other Head of Cancer lecture series are also under that playlist. If you'd like to schedule an appointment or have questions regarding a potential cancer concern, please feel free to call our Hope line at 412-578-4673 to schedule an appointment. And again, thank you everyone for attending tonight. Have a great evening.
Thank you very much.
Thank you.